Hi, this is Gregg STONE, and it's my pleasure today to present a case of definite stent thrombosis from the Excel trial. These are my disclosures. So this patient was a 64-year-old man who presented with unstable angina. He had a past history of non-insulin treated diabetes and hypertension, a well-preserved left ventricular ejection fraction, and a site-reported syntax score of 24. This shows his right coronary artery on the left. You can see it was pretty normal. And his left coronary artery is on the right, which shows a Medina 111 left main lesion. Here we go, other views of the left main coronary lesion, spider view, showing the lesion is severe distally and in the circumflex, and in the iliocranial, you can see LAD involvement. So intravascular ultrasound was performed from the left main to the LAD, and here are selected cross-sectional images. You can see the distal left main is fairly severe, some calcification. The bifurcation lesion also moderately severe. The LAD ostium has what looks like a calcified nodule, and the distal LAD reference has some mild disease. You can see the vessel measured about 4 to 4.5 millimeters throughout the left main coronary artery. The LAD ostium was about 3.1 millimeters, and then it expanded to about 3.7 millimeters, a little more distally. Those are the reference external elastic membrane measurements. So the left circumflex and the LAD were predilated, and then the operator decided to do a culotte technique, and a 3.0 15 millimeter stent was placed in the distal circumflex artery. Here you see the stent being placed on the left screen, and on the right screen you see the angiogram after the stent was placed. You can note that there is a stenosis distal to the stent, but this was not treated at this time. So that was a 3.0 15 millimeter stent. So the operator then put a 3.5 18 millimeter stent to the LAD going back into the left main. Here you can see the LAD positioning of the stent on the left screen. And then there was an edge dissection after that stent was placed, so we put a second 3.08 millimeter stent to the proximal to mid LAD. And here you can see the angiograms after the LAD stenting. You can see good patency and minimal residual stenosis in the left main and the LAD. You'll notice though in the circumflex that there's a fairly severe stenosis after the circumflex stent, possibly an intramural hematoma. This was not treated at this time. We don't have the reasons one way or the other, but of course this wire was trapped, and so the wire was pulled. As you see on the right, the operator performed a left main and LAD pot, multiple LAD post-dilatations, trying to rewire the true lumen of the circumflex, but was unable. And so you can see a wire in this high-rising first obtuse marginal branch, but the main circumflex artery was never rewired. So the operator then performed IVUS, again, of the left main and the LAD, and here's some selected images. And basically, you see very good expansion in all the locations. The left main minimal stent area was 9.3 millimeters squared, and the LAD ostium was 7.3 millimeters squared. This is a final IVUS run from the LAD to the left main. Here you can see that calcified nodule. But still, the overall stent expansion is quite good. Lumen is good, the stent is well opposed, no edge dissections, no malapposition. And here we are in the left main. So this is the final angiogram. And you can see there is flow into the circumflex artery. The left main and the LAD look very, very good. Perhaps the proximal ostial LAD looks like a 10% stenosis angiographically, but it looked good by IVUS. But you can see this quite severe stenosis after the circumflex stent. And here you can see mainly the LAD on the right-hand image. So the patient, after the procedure, was asymptomatic, no periprocedural infarct. He developed bleeding from the left groin, which was treated with 2 units of blood transfusion. Because this clopidogrel was withheld, and the patient was discharged 4 days later in stable condition on aspirin only, without clopidogrel or another P2Y12 inhibitor. The patient was well for 1 week and then had increased dyspnea and chest discomfort, which were intermittent for 2 days. He consulted his general practitioner. To our knowledge, nothing was changed. On day 13 after discharge, which was 17 days after the stent was placed, he had severe chest pain, marked dyspnea, and an ambulance was called. During the ambulance transport to the hospital, the patient had a ventricular fibrillation arrest and CPR was initiated. In the CCU, the patient had recurrent ventricular fibrillation and pulseless electrical activity. He was taken to the cath lab with CPR ongoing. Here's his EKG at the urgent admission. You can see marked diffuse ST segment depression with ST segment elevation only in AVR, which sometimes is indicative of a left main occlusion. And here's the angiogram while CPR is being performed. And you can see there's total thrombotic occlusion of the proximal left main coronary artery. So the operator performed thrombectomy, ballooning, placed additional bare metal stents, all without improvement. Here you can see intermittently with CPR being withheld, a little bit of flow restored into the LAD and minimal branches, but essentially TIMI 0 to 1 flow. And you can see there was never flow restored to the apical LAD and never flow restored to the circumflex artery. Unfortunately, this patient, as you might expect, expired in the cardiac catheterization laboratory. So this was an unfortunate case of a severe stent thrombosis in the Excel trial. We did not have many stent thromboses in Excel. The rate was only about 0.7%. Perhaps 1.1% definite or proximal later. In this case, clearly, I think what contributed to the stent thrombosis was the fact that first, the patient had a severe outflow stenosis in the circumflex artery. So a stent thrombosis of the circumflex would not have been surprising. But here we had stent thrombosis in the left main. And I suspect what happened is because the patient was discharged on aspirin only, when the circumflex occluded, the thrombus propagated proximally and into the left main. Maybe the left main occlusion might have been prevented had the patient been discharged on dual antiplatelet therapy, but that, of course, is total speculation. So an unfortunate case, a rare case of stent thrombosis from the Excel trial, showing the importance of optimal technique, optimizing all stenoses, not only at the stented sites, but also both inflow and outflow stenoses, and necessarily the importance of optimal pharmacotherapy. Thanks very much.